It appears that using a CD28 costimulatory domain can make the cells grow faster and rapidly expand. So this may have practical implications. The axi-cell product, the median turnaround time is 17 days. So for patients who are waiting to get this therapy urgently, this may be an important consideration. But at the same time, it should be noted that at least from the data which we have, that the rapid expansion could also possibly lead to higher CRS and higher neurotoxicity. It would be hard to compare between the different studies because these are not randomized studies, but based on the data what we have, this is the conclusion which I can arrive. The other thing which would be interesting to see over time would be if the costimulatory domain choice helps you figure out about persistence of CAR T cells in the long run, and also if it has effect on T cell exhaustion.
Well, personally, I don't think that you can compare them directly from a toxicity standpoint. I think that individually you can discuss their toxicities, but to try and compare and contrast, because they have not yet and may not ever be compared head to head. And maybe they will in some setting in the future. And I think that's really the only way that we're going to really, with as best of definitive notion that we can, say that one CAR T cell construct is better or safer than the other. So if you want to just take a step back and say, looking at the patient population for which axi-cell was studied in, and using their CRS guidelines, there was all-grade CRS, I believe, was in the 90% range, and all-grade neurotoxicity was, I believe, in the 50% range, and they had very, characteristic days of onset for the CRS and if neurotoxicity with broad ranges with regards to the toxicity. But that toxicity, can be mitigated or reduced, hopefully with the use of tocilizumab, which blocks the IL-6 receptor. And then if neurotoxicity does occur to a significant grade, then dexamethasone can be used to help lessen the severity of the neurotoxicity. Now, speaking towards the toxicity profile with the other constructs, again, it's very difficult because specifically in the T-cell, they used a different grading scale for CRS. So that's where it becomes very difficult to kind of jump in between, grade 1, 2 or grade 3, 4 toxicities between constructs. And I think you really have to, acknowledge different lymphodepleting chemotherapies, different patient populations, different dosing, different disease burdens. Some of these patients were unable to get bridging chemotherapy, whereas the vast majority of the patients with other constructs received bridging therapies. So how that plays into the differences between constructs and between toxicity profiles and safety profiles, I don't think that we can say right now. We can only report the numbers and hope that those numbers we can either increase them, increase the safety. We don't want to increase the toxicity. We want to increase the safety by finding strategies or algorithms that leads to lessening of the toxicities without compromising efficacy.
The follow-up for these studies have not really been that long. However, the Juliet study and the ZUMA-1 study have a little bit longer follow-up than the Transcend study. So the median follow-up for the Juliet study is 14 months as reported at EHA 2018, and the median follow-up for the ZUMA-1 study has been about 15 months. The median follow-up for the Transcend study, which was reported at ASCO 2018, was less than a year. It was actually about a year for survival endpoints and 8 months for the durability of responses. So longer follow-up is obviously needed, but it does appear that a 3-month time point is a very important time for looking at responses and could predict the long-term durability of response if someone is at a complete response at 3 months.